kind of what are sort of medication adjuncts that folks can use for to help with the care of the patient with severe hypoxemia when someone has is as Dr. Scott was alluding to, is on 100% 10 of PEEP, and you're maybe getting an O2 sat of 90%. What are some of the things that our listeners should know that they can utilize to reduce some of these difficulties?
So the first thing I would recommend is making sure that your patient is adequately sedated with both analgesia and sedation. Sometimes we forget to use those fentanyl drips, but making sure that they're adequately sedated. And then if you end up with the ventilator desynchrony, you can always paralyze the patient, but making sure that you do have that adequate sedation on board as well. And to make sure that the patient is paralyzed appropriately, a lot of facilities will usually use train of 4 and titrate the paralytic to 2 twitches. But if you do have a BIS monitor, this really will help with determining if the patient is adequately sedated, because the range that we would want would be between 40 and 60. Now, most facilities don't have a lot of BIS monitors for every single patient that is on a paralytic. But titrating this willy-nilly can really be harmful to the patient and potentially could propagate some problems in the future, because patients with ARDS on paralytics, we're usually seeing them on it for a long period of time, 5+ days, potentially up to 2 or 3 weeks, depending on how quickly their lungs heal from the ARDS. Something else that we're doing is proning the patient, and we're keeping them prone for actually a longer period of time of up to 18 hours, because that really seems to be working for our patients. And then in those really, really sick patients that we have, potentially we're trying nitric oxide or inhaled prostacyclines, but I haven't seen that be very successful in these patients.
No, exactly the same here. Yeah. So adequate sedation, adequate analgesia, neuromuscular blockade. Historically, the most common agent we've used in the ICU has been cisatracurium. There have been a lot of shortages of cisatracurium or Nimbex nationwide. So some of the other non-depolarizing blockers like vecuronium or rocuronium can and very easily are used instead of cisatracurium, although cisatracurium is sort of the default historically.
I'd like to add 2 things to this
Yeah.
question. We've had really great success with dexmedetomidine or Precedex with our population of patients. And during the COVID pandemic, we've actually opened up the age range. So we take up to age 30 in the pediatric ICU. Not needed to take too many of those, but a couple of them have been in the upper 20s. But it's something that we routinely use with our intubated patients, so we have great success with that. And the other caveat in terms of speaking about the ventilator and just one piece to the setup of it, it's the double filter that's now in place, recommended with the COVID positive patients, to recognize that there are special airborne filters that go on that are the appropriate micron size for the virus.